Welcome everybody to this second CHE Policy Forum. Welcome to those in the room. We had a bit of a kerfuffle with room location, so we might have people coming in at various stages in the next 10 minutes or so. And welcome to those online as well. My name is Mark Scolfer. I'm head of department of Centre for Health Economics, University of York. The idea behind these policy forums is actually to celebrate CHE's 40th birthday, and CHE has been focused on policy relevant research to inform the decisions of policymakers and others for pretty much all those 40 years. We've had, for example, policy research units for at least 20 years supporting decisions in the Department of Health and Social Care and its arm's length bodies. And the idea of the policy forums is to showcase some of that research and to invite two external colleagues to review that work. So today we've got Beth Woods, who's a senior research fellow here at CHE, presenting on how much should we pay for innovation, fair pricing for pharmaceuticals. And we have two externals who've kindly agreed to join us today. Adrian Taus, who's Emeritus Director of the Office of Health Economics, and Keith Derbyshire, who's honorary professor here at Centre for Health Economics, but former chief economist, chief analyst at the Department of Health and Social Care. So the format is that Beth will talk for about 35 minutes. Actually, I mean, no more than 35 minutes. After which Adrian will speak for no more than 15, hopefully less, and then Keith, and we'll hopefully have good amount of time afterwards for questions in the room, but also online. So encouraging those online, please, to post your questions. And I think there's an opportunity to upvote those or downvote them, I guess, online as well. For those in the room, there are some handouts at the back if you want to pick those up. The other last thing to say is that in terms of the sort of selection of discussants, we try and pick colleagues who have slightly different perspectives. So obviously both Keith and Adrian are economists who've got very clear views about this and many other areas. Keith has a long association with government, and I'll read out their bios before each of them speak. Adrian has worked very closely with British pharmaceutical industry and the industry internationally as well. So they bring, as well as their independent economist views, they bring those perspectives as well. So I'm going to speak no further at this point. I'm going to hand over to Beth.
Thank you, Mark. Can I just check that my mic's working? Okay, so the outline for my talk today is to introduce our research project, to talk about this idea of the innovation paradigm, then to provide a number of insights from our research, and to finally provide some policy implications from the work. So this is work conducted as part of our Economic Evaluation Policy Research Unit, EPRU, and I'd like to acknowledge the whole team that put these two pieces of research together. You can find out more about the work in these three documents. These describe, the first document describes our first project, which was looking at estimating the shares of the value of branded pharmaceuticals accruing to manufacturers and to patients served by health systems. So really, this was looking at the question of how is value currently shared in the UK, given the current pharmaceutical pricing environment. The report and the summary below it answer a different question that naturally followed on from that first piece of research, which is, what would an optimal payment level look like? And the usual disclaimers apply. Of course, this work is the view of the authors and not necessarily our funders or any other individuals or bodies. Okay, so it's perhaps useful to approach this question firstly by thinking about, what does cost effectiveness analysis tell us about what a fair price might look like? So it's a principle of cost effectiveness analysis that an intervention is cost effective if it's cost effective relative to an appropriate measure of health opportunity cost. So what do we mean by that? Well, health opportunity cost describes how much health can be achieved via alternative uses of healthcare resources. And this is an empirical question that's addressed by research that's been conducted in the UK and internationally over the past decade. And I think, as Keith might mention a bit later on, an operational value of £15,000 per QALY is used routinely by the Department of Health and Social Care. So in the context of a new pharmaceutical that delivers a 2 QALY health gain, this would be considered cost effective according to conventional principles of cost effectiveness analysis if the additional price per patient above and beyond existing technologies was up to £30,000. If we spent any more than that, we'd be displacing more healthcare than the gain in QALYs that we'd get from using the pharmaceutical. But this isn't how pharmaceutical pricing policy operates in the UK. So an important component of that policy is the NICE cost effectiveness threshold, which I'm going to refer to as an approval norm. And this doesn't reflect health opportunity cost. Historically, NICE has used a range of £20,000 to £30,000 per QALY as its approval norm, though increasingly a range of exemptions permit pricing to approval norms of £50,000 per QALY and beyond. So we've seen this in various different aspects of policy, end-of-life criteria, the use of severity modifiers, but also different thresholds being applied to highly specialized technologies when we may see cost effectiveness thresholds or approval norms in excess of £100,000 per QALY. So the use of these high approval norms has led a number of commentators, and you'll see the references at the bottom, suggest that perhaps NICE is doing more harm than good. So what does that mean? Well, if we think about a £10 million expenditure on new pharmaceuticals, then we can think about how much those new pharmaceuticals would be expected to deliver in terms of health at different levels of cost effectiveness, so at different approval norms. So if we use an approval norm of £20,000 per QALY, we'd expect to get 500 QALYs from that £10 million worth of expenditure. But in terms of the opportunity cost, we'd expect that to be 667 QALYs if we use the operational measure used in the UK. And we'd see a net harm to patients of 167 QALYs. And we can do those calculations and look at the implications of different approval norms. For example, if we use an approval norm of £50,000 per QALY, we see an overall harm to NHS patients that's much larger, at approximately 500 QALYs lost. But this type of assessment has led to questions about whether this way of looking at things really reflects the reasons we pay high prices for new pharmaceuticals. And this is sometimes described as the innovation paradigm. So this is the idea that new branded pharmaceuticals are awarded intellectual property protection that allows them to command a high price at the start of their life cycle. And the idea of this is that it encourages and supports innovation, and that innovation predominantly takes place in the private pharmaceutical and biotechnology industries. In return for that, when this protection runs out and medicines become older, they're expected to face price competition from generics and biosimilars. So we can think about what this might mean for the value accruing to different parties. So if we look at the top panel of this slide and think about manufacturer revenue, we see a typical profile where initially there's an increase in uptake, and then perhaps a fairly even revenue stream as intellectual property protection's maintained. And then when that's lost, a gradual loss of revenue as either the company has to reduce their prices to compete with generics and biosimilars that enter the market, or the originator company decides to exit the market and pursue other opportunities. We see a quite different pattern when we think about population health. So this is the lower panel on this graph. And what we see here is that during the period of intellectual property protection, medicines typically achieve a price such that the health benefits of the medicine are more than offset by the health opportunity costs of paying for it. So that's the idea we saw in the earlier slide, that perhaps NICE is doing more harm than good. However, once generic and biosimilar products become available, the NHS is expected to accrue significant value from the innovation, as it can purchase that innovation at a much lower cost. So this, I think, paints a more refined picture of the fact that the value the NHS accrues and how value is shared between patients and manufacturers depends on a number of factors. It depends on pricing for new medicines, the period of intellectual property protection, and the functioning of the generics and biosimilars market. So more carefully reflecting these different features across the life cycle of a new pharmaceutical was really the motivation for our first piece of research that aims to answer this question of how is value currently shared. So our starting point for this work was to try and reflect the full life cycle value of a new medicine. And we call this TB. So this is the total value available if we could purchase a product at generic or biosimilar prices, so at the costs of production. So this is calculated as the QALYs gained minus any health opportunity costs or savings, the health associated with any savings of using the product, minus any health opportunity costs associated with the additional costs of producing the medicine. And importantly, this reflects multiple cohorts over time. So of course, we don't just have patients starting on a treatment today. We expect the medicine to be used into the future. And it also reflects value that accrues in the patent and the post-patent periods. Of course, so in a sense, this can be thought of as the size of the pie to share. But we need to think about how much of that is accruing to the manufacturer and how much of that is accruing to the health system. And that partitioning of the value needs to account for the prices paid during the period of patent protection. So we parameterized our model using data from 12 NICE appraisals. And these provided estimates of health gain and additional health system costs. You might be thinking, NICE has conducted lots of appraisals. Why these 12? Well, it was a convenient sample that was actually based on work that was done looking by a group in Sheffield, looking at the implications of using different quality of life instruments. But the reason why we wanted to use it is because we were able to access both QALY estimates, but importantly, ICERs and cost estimates that reflected confidential discounts. So they reflected the patient access scheme discounts that are typically agreed during the NICE process. And this was really important, as that's the price the NHS actually pays, as opposed to the list price, which is often not reflective of that transaction price. We also used a range of other data. I won't have time to go through this in detail, but that was really to capture this pattern of patients initiating treatment over time, and also the period of intellectual property protection and the features of the generics and biosimilars markets. So these were our results in terms of our findings about how value is currently shared. So I think it's useful to think about these drugs used in these specific indications in three groupings. So the first grouping above the dashed line are drugs that were approved at incremental cost effectiveness ratios that fall substantively below our estimate of health opportunity cost. And what we see for these products is that patients accrue between 81 and 94% of the value, and the manufacturer share is relatively low, between 6% and 19%. If we then look at the middle segment, we see quite a lot of variability. So these are all products which were approved at incremental cost effectiveness ratios that were within that typical NICE range of 20 to 30,000 pounds per QALY. And what we see here is that for enzalutamide, patients accrue 21% of the value, with the manufacturer accruing the remainder. But for the two biologics, we see a bit of a different pattern. And what we see here is that the manufacturer actually accrues more than 100% of the value of these drugs. And the NHS is left with a negative impact on overall population health. And the reason for that, if you think back to the earlier slide with the bars, is that those losses in health during the period of intellectual property protection are so great because the prices are high that we don't see the benefits in the patent period offsetting those initial losses. So overall, we're still left with a loss. So why does this happen for these two drugs? Well, there's a number of factors contributing to this. So firstly, we know that when we have biologic drugs, it takes longer for the biosimilar, which is a bit like a generic, to become available. That's just a slower process. They're more complex to produce. Those biosimilars are also a lot more expensive. They've come down in price over recent years, but they're still much more expensive than small molecule generics that we've been used to seeing. And we also see a pattern for these two indications where usage of the drug is expected to be focused in the patent period, as there are a lot of prevalent cases that need to be treated with these medications. The final set of drugs are a set of drugs that were approved according to NICE's end-of-life criteria. So these drugs were priced close to the effective operational approval norm under those criteria, which is £50,000 per QALY, which was used for a period by NICE in contexts where products were expected to extend life and to be used in patients with short life expectancies. And what we see for all of these products is that the manufacturer share of value far exceeds the overall value delivered by the product. And the patient share is negative, i.e. we expect to see overall in the long term losses in population health. It's also interesting to think about what these payment policies are doing to incentives. So I had a little look at that overall population potential value. So what is the overall value of these new products, and plotted that against the payment received by the manufacturer. And what we see really is that it's kind of all over the place. If we had a value-based pricing system that was really drawing through the most valuable products, we would expect to see these sort of clustering around a line that closely related payments to value. And I think the worry is here that we are over incentivizing low value products, but also potentially under incentivizing high value products. And that means that people won't invest enough and they won't take the risks on those high value projects. Okay, so our second research question was to think about, well, okay, the picture doesn't look good. It looks like we're paying too much, and it looks like we're not giving the right signals to private investors. What could we do differently? How should value be shared? So for this work, we took a population health perspective. So I'm going to start by providing our findings, assuming that the primary objective of healthcare spending is to promote population health. I'll talk towards the end of the presentation about how our findings might change if we had different or broader objectives. But if we take a population health perspective and we're thinking about, well, what should the share be? It's useful to think about what are the costs and benefits of paying a higher share. Well, assigning a higher share is expected to stimulate more innovation, and those innovations we hope will have health benefits in the long run. And those health benefits are just as real as the benefits that we get from drugs that have already been developed. So that's on the benefits side of paying a higher share. But we also need to think about the costs of paying a higher share. And those costs are that we impose larger health opportunity costs for medicines that are already developed, but also for medicines that are developed in the future. So really, this research was about trying to work out how to balance those consequences of paying different shares of value. So an important consideration when balancing those two effects is understanding how much paying a higher share, paying more for new innovation actually leads to stimulating the innovation environment and leads to more and better products. So we conducted a systematic review of the literature examining the effect of payment on innovation outputs and outcomes. So by that, I mean, how many new drugs were we getting and how much benefit did they provide? And we focused on studies providing plausible or robust causal effects. What we found from that work was that there were a wide range of estimates of the quantity of innovation elasticity. And there was a lot of unexplained heterogeneity. And perhaps most worryingly, that heterogeneity and the relationship we saw between the uncertainty and the size of the effects was consistent with publication bias, reporting bias, or quality issues with those studies. So for those reasons, and under those circumstances, a standard meta-analysis isn't recommended. And instead, we decided to present our results for a range of potential values for the value of innovation elasticity. So for our central estimate, we use an elasticity that was produced by a simulation study conducted by the Congressional Budget Office in the US. And we also used a range based on a high-quality study conducted by Dubois and a simple averaging of a selection of studies conducted by Philipson and Jury. So what does that 0.45 estimate mean? I don't know if anybody apart from economists like elasticities. Well, I certainly don't. So what that means is that if we have a 1% increase in revenue, then we'd expect to see a 0.5% increase in the number of new drugs developed. So that's all that means. But we present our results for a range of plausible estimates. We found very limited evidence of the effect on quality of innovation. We identified one study that did look at this empirically, and that estimated that a 1% increase in the quantity of innovation resulting from higher payment was associated with a 0.5% decline in quality. And quality there was measured as improvements to median survival, which is consistent with the broader evidence on the effects of payment on innovation quality measured using regulatory metrics around product novelty. No literature was found relating payment to manufacturing costs, though it seems fairly logical that if we start paying a lot more for new pharmaceuticals, then we'd expect those two on average to get more expensive to produce. So given the paucity of evidence on these two aspects, we've excluded these effects from our headline figures, but we show some results with a quality adjustment included as a sensitivity analysis. So, of course, innovation doesn't just respond to what's happening in the UK, it responds to the global market for medicines, of which the UK is actually a relatively small part. So this creates the potential for suboptimal levels of investment in innovation if individual countries don't take account of the effects of their national level pharmaceutical pricing policies on other jurisdictions. So for the research I'm presenting today, we assume that either a global multilateral policy is in place for rewarding innovation, so all countries move together, or equivalently, that countries account for the external effects of their pricing policies on other jurisdictions. Of course, if we didn't make this assumption, the optimal value shares and the optimal payment levels we found would be much lower. So this is our conceptual and empirical framework in a nutshell. This is how we balance costs and benefits. So on the x-axis, we have the share of total value assigned to the manufacturer. And on the y-axis, we have the health benefits from existing and future medicines. And what we see, as we would expect, is that the overall benefits are responsive to the share as we get more innovation. However, the total costs are increasing with share. So if we didn't allocate any share of value, we would get the benefits associated with drugs that have already been developed if we just played cost of production. But of course, we wouldn't get any of the dynamic benefits. Whereas if we assigned all of the value to the manufacturer, we would get the maximum possible within this graphic in terms of the potential benefits. But of course, we'd have given all of that value to the manufacturer. So what we really need to look at is those net benefits, which trade off those benefits and costs associated with assigning different shares of value, and to identify the sweet spot where we maximize our net benefits. Of course, where that optimal level of share sits depends on how responsive innovation is to how much we pay. So we've got values of the innovation elasticity here on the x-axis, and then this dark line here shows how the optimal share of value increases as the value of innovation elasticity increases. And what we find is that using the CBO estimate of the elasticity, our optimal share sits around 20% if we don't adjust for quality, and around 10% if we do adjust for quality. So it's useful to think about, well, that's all very interesting, Beth, hearing about shares, but that isn't how we pay for pharmaceuticals. We can't assign a share. So how do we convert this to policy? So optimal shares allow the optimal total payment across the population and product life cycle to be determined by multiplying the total benefit by the share and then by a measure of health opportunity cost. This isn't how we typically pay for medicines, which are typically priced per tablet or per vial. And I think a benefit of this framework is that it doesn't hinge on a particular way of implementing payment. So once you work out the optimal payment level, you can implement that via a range of policy instruments. So that could be modifying approval norms, and we illustrate that in our work. It could be via rebates, which are often a feature of pharmaceutical pricing policy, whereby the manufacturer pays back some money to health systems. We could modify the intellectual property protection infrastructure, or we could look at securing commitments to lower prices beyond the period of intellectual property protection. Or we could even look at some of the more innovative payment options that have been discussed in the literature using subscription-style payments. So in our paper, we do show our results translating to approval norms, as that's often a feature of reimbursement policy in countries that use cost effectiveness, but it's not a necessary component of this work. We have a lot of flexibility in thinking about how that overall optimal payment could most effectively be translated to a pricing policy. So we went back to those 12 NICE appraisals and we had a look at what optimal pricing would mean for payment levels. So we can divide the drugs now for simplicity into two groups, and also because Mark's given me the 10-minute signal, so I better crack on. And what we see is that for those drugs that were approved at incremental cost effectiveness ratios that were well below our measure of health opportunity cost, we see that the optimal price premium, so that's the amount per patient that we're paying above and beyond whatever the comparator is higher under the optimal pricing than it would be under the existing pricing policy. However, what we see is that for all of the drugs that were priced in line with NICE approval norms, we see that the optimal price premium is radically lower than what we would see under existing pricing infrastructure. But as well as thinking about what this means for payment, so it looks like overall we're paying too much and we should lower our prices, it's also useful to think about what a change in our payment mechanism would mean in terms of the incentives it would send to industry. So it would mean that instead of this very scattered plot with a lack of relationship between benefit and payment, we'd hopefully start to see something more scattered around this line that better tied payment to value and therefore discouraged investment down here, but perhaps encouraged more really high value, risky and costly investments. So I'll finish up with some policy implications of this research. So our objective of this work is to support the design of pharmaceutical pricing policy that promotes long-term population health. Our findings suggest that in the UK, population health promoting pricing levels for new pharmaceuticals would be lower than current price regulation supports. So we found under our base case assumptions that the population health maximizing share would be around 20%, whereas the shares we found when we looked at current policy were often in excess of 100%. Would this type of change to pricing result in less innovation? Yes, it would, but hopefully that would be better innovation from a population health perspective. And our work suggests that moving towards the optimal share provided by this work would increase the overall health benefits of new medicine expenditure by between 24 and 144%, with our assessment that the 144% is probably more accurate. Of course, we had to make assumptions in this work, and there are uncertainties in the evidence base. However, the optimal share of 22%, I think, is on balance likely to be generous for a number of reasons. Firstly, we didn't account in our base case analysis, though, for that 22% of impacts on quality and manufacturing costs. And we know from theory and some empirical evidence the direction of those effects. And that if we have more innovation, we pay more innovation, we'll start to see those diminishing returns on quality, and we'll start to see products that are more expensive to produce. We're also assuming, unlike Green Book recommendations, that we should take account in full of external benefits on other countries. If we didn't do that, it would suggest a much lower optimal share. And finally, we haven't accounted for the contribution of publicly funded R&D. So it might be legitimate to say that actually patients and populations deserve a bigger slice of the pie, as they've actually paid for some of the fundamental research that supports the development of new drugs. A second consideration is, of course, that total population QALY gain, might not be the end of the story. It might not be the only relevant policy consideration. It's in fact unlikely to be so. There might be other elements of health that are thought to be important. There might be wider social benefits of using new medicines that we want to reflect, or we might care about how health benefits are distributed. So this alters our definition of benefits, and it also alters how we measure health opportunity cost. But I don't think that that means that we'd see a very different picture in terms of the optimal share. We also looked in our work at a broader definition of welfare, accounting for both consumer and producer surplus, and found our results were robust to including producer surplus. Okay, last slide before Mark comes and drags me off. So in terms of practical implications in the UK, further price regulation could be achieved via existing mechanisms like lower NICE approval norms or higher discounts via existing rebate schemes. I think Keith's going to talk a bit about the voluntary scheme in his presentation. I think there's some really exciting new ideas about how we better get prices down in a way that could move us towards optimal payments whilst reducing the negative effects on innovation. So, for example, the statutory scheme, gosh, that's a mouthful, proposals under consultation include a life cycle adjustment whereby towards the end of the patent life and beyond, the rebate kicks up, which I think is really nice. We can perhaps talk about that a bit in the discussion. But I think it's also worth recognising that current systems are complex and there may be benefits to separating out appraisal from pricing functions. Okay, let's be done.
Thank you, Beth. Perfect time. Thank you very much. So I'd like to introduce Professor Adrian Towse now. So Adrian is Emeritus Director of the Office of Health Economics in the UK. His current research interests include incentives for new drugs and vaccines to tackle antimicrobial resistance and the use of risk-sharing arrangements between healthcare payers and pharmaceutical companies. He's a visiting professor in practice at the London School of Economics and a non-resident fellow of the Centre for Global Development. And he's been a visiting professor at the University of York and a visiting senior researcher at the Nuffield Department of Population Health at the University of Oxford. For 10 years, he served as a non-executive director of the Oxford University Hospitals NHS Trust, which is one of the UK's largest hospitals. And Adrian was also president of ISPOR between 2014 and 15. He joined OHE in 1993 and served as its director for 25 years. Adrian, thank you very much. It's you.
Okay, thank you, Mark. Thank you. So I'll put my timer on. Thank you very much for the invitation. I vaguely remember a 25-year celebration of Che, and thank you for inviting me to that as well. I won't be around for the 50th, although I'm sure Che will, but I'm retiring at the end of this year completely. So this is my swan song as far as participation in York events is concerned. So the best way for me in terms of thinking about Beth's presentation is think about a straightforward demand and supply curve where the price is effectively the price for a unit of health gain. And the first paper is looking at the area above the price. So looking at that consumer surplus and saying, well, is the NHS getting its fair share of what that consumer surplus should be? And I think the second paper is looking at that area underneath price where you get to the area below price but above the supply curve, which we typically call the producer surplus, and saying, well, hang on, can't we have some of that producer surplus and increase the amount of money we've got for health by paying less for innovation? So if we turn then to the first paper, which is really on the above the price, the consumer surplus side. So we're starting with value accruing to the innovators, the NHS, or the patients. And as Beth said, shares matter. The innovation paradigm, as she calls it, I call it the social contract, is the innovator takes most during the patent life, the health system, the patient take most once it's off patent. Now, the issues, a couple of issues, and Beth presented this work very well, but the couple of points I would make is we're assuming a budget-constrained NHS here. If it's the only global customer, then we still need to deduct R&D costs. But you don't do that because in practice, it's a piece of work that links into your second paper, where in effect you're just concentrating on static benefits. But if you don't reward R&D and take off R&D costs, then there isn't any more R&D beyond that. I think imposing the 15K threshold to generate your results means that you end up showing NICE doesn't use a 15K threshold. But I think we knew that already. And as you pointed out, 5 of your 12 are end-of-life products. And it seems to me if you'd use the approval norm, as you put it, but the policy threshold that NICE was using in each case, then it would be clearer what the consequences were for that value of the off-patent impact of pricing. And then you've got the obvious question, which is, would the NHS have expected a bigger impact once the product had gone off patent? But I think these are sort of minor points. I think for me, the critical point is the off-patent price reductions impact not just the immediate product, but change the comparative price. And that is a very fundamental point that comes out of your analysis. So in other words, we take simvastatin, high price comes down, low price, generic price falls 90%. At that point, every other statin that the NHS is using should be being compared with that generic price of simvastatin. So effectively, you're lowering the whole class. And that is potentially, if it's done properly, has a very significant effect on the end. And it's an effect whether or not people are using simvastatin, because everything else is being pulled down as well. But I'm not clear whether you include the sort of follow-on effects, because then the whole system is being dragged down. So the next wave of innovation has to use the lower starting point as well. So there's the whole headroom area is being changed. But I think the key point is you can do plausible life cycle value estimates, and we should be using them to inform policy. Now, Beth said that what I've called the social contract at the moment effectively gives us value-based pricing, high price during patent, low price beyond that. And paper I was involved in, we called it value-based differential pricing. We get optimal global innovation. Optimal global innovation. If each health system sets its own price, reflecting its local opportunity cost threshold. But of course, the problem with this is we're assuming that we have an optimal patent life, but we don't know, as Beth's paper, as the EPRU paper points out, we don't actually know what an optimal patent life is. So there is an issue there. Now, the Pandy, Paulden and McCabe focus on consumer surplus, assuming the patent life is infinite. That's a sort of minor, and I'm not going to pick that up. But the point is they start focusing on the supply curve for innovation. And they're saying, well, hang on, we think about this bottom part. So we've got the price of health gain, and then we've got a supply curve coming like that. And essentially what they're saying is, well, hang on, there's intramarginal rents that we're giving away by having a uniform price for health gain. Surely there's some way that we can get some of this producer surplus and add it to our surplus. The same innovation at best, but more consumer surplus. And my paper I wrote with my colleague, Michael Berdut, and others shows that it's actually more complicated than that, but more on that later. But that, in a sense, I think that paper is in some ways an intellectual precursor, and no doubt there's a history, I know, collaboration and thinking between IHE and Che, but it seems to me that that's in some ways a precursor of some of certainly the thinking around the second paper that Beth presented. So why do we need to think about these shares of social surplus? Well, apart from wanting to pay for less for innovation, then as Beth's paper points out, we have new payment models such as subscription for antibiotics. My colleagues, Grace Hampson and Lottie Stoyton, set out recently a paper where they were looking at when might a subscription model potentially be appropriate. And of course, Beth and others here in the Che team were involved in doing the value assessment that NICE used in order to set subscription levels for the first two new antibiotics in the subscription model. In order to do that, you're calculating health benefit over a 20-year period. NICE then has to make an assumption about how much of that and what share should the manufacturer get in the subscription model. Now, it also applies in the case of curative therapies, because effectively this is a paper I did with Liz Fenwick. But if we compare the same health gain delivered, but once it's a pill that you take every day, the other is a one-off treatment. The one-off treatment during the patent life, all the benefit goes to the manufacturer under value-based pricing. The once a day, when the product goes off patent, the price goes down and the cost of delivering that health gain will change. If you think about the extreme, where we've got something that cures a disease and we eradicate it completely, and we do that during the patent life, then all of the value will go to the innovator, because effectively there is no off-patent period during which there are patients turning up who are getting a low price. So the advent of one-off treatments does slightly change the paradigm. And the third point here is No Patient Left Behind, a US group commissioned to work on the value of medicines, published by Entity Risk, talks about the need to incorporate dynamic pricing when you're assessing value. So in other words, you take into account the reduction in price that you expect to occur at the end of patent expiry, you bring it all up forward, you add it to value, and you say, well, we should take account of this when we're deciding what the price should be. And the difficulty with that, if you don't introduce some share taking of some sort, then effectively you're saying all of the social value should accrue to the innovator. So to go to the second paper, and a subsequent draft of a journal article that Beth shared, then 3 key points. The assumption is maximizing health, and the estimates, as she said, come from the CBO report, although a couple of my colleagues have criticized some aspects of the CBO model. But the key conclusion then is potentially a policy instrument to achieve dynamic efficiency, where the payment is now, for the NHS, is now some function of the optimal social care times the opportunity cost, K, times the static benefit, rather than, if you like, and I'm putting this very crudely and it's not right, but the current model where the price is K times whatever is the health gain in the particular year that you're applying you're doing the assessment. There are a lot of assumptions. I'm going to quickly come to one of those in a moment, but it seems to me also there's a key issue of implementation. How do you do this? And I'm thinking in particular of the health impact fund type issues that Aidan Hollis tries to deal with, any sort of patent buyout, where how are you estimating what the life cycle effects are going to be so you can grade out what those payments are going to be to the innovator. So 2 quick concerns. We're using an average constant elasticity of R&D response. The 2 things that are straightforward in this model: absolute size of health gain matters. That's great. Your willingness to pay for health gain matters. That makes obvious sense. But we're averaging across disease areas. And the Dubois et al. Finds different supply curves. Well, that's my 10-minute warning. That tells me I've had 10 minutes. It doesn't mean I've got another 10 minutes. Actually has different numbers. So you'd expect the fundamentals about finding treatments in different disease areas to be different. And what we did in our paper here is we also modeled a non-uniform distribution of reserve ISAs. I don't think, yes, I can. So we've got 2, this is the curve of the, if you like, the consumer benefit. We've got health gain on the y-axis, but along the x-axis is not share as in Beth's model, but this is just K, effectively lambda, the opportunity cost threshold. And this is with a uniform distribution on the supply side. We end up with a threshold here. If we have a non-uniform, then we're on the red and we end up with a higher threshold. So the shape of those curves actually has an impact on what the optimal threshold is going to be. So it's pretty important. But I think my main concern is the danger that if we're estimating a supply curve in this way, we end up with too little innovation rather than too much. And if we look on the face of it at life cycle share studies of major drug breakthroughs, 2nd-generation antipsychotics, statins, HIV/AIDS, the Hep C treatments, then they actually show innovator shares that are well below 22%. So no problem. But I think what these studies show is that when we've got high social value therapies, competition and differential pricing and use of payer bargaining power is going to push down the share of innovator value a lot. So it's the other way around. It's the effect of having a lot of social value that then leads to mechanisms that reduce the innovator's share. So the great danger, we're using ex post share of value, whereas the investments decisions are taken ex ante. Again, the gains, sort of Murphy and Topel, a 1% reduction in cancer mortality might be worth 500 billion. More recent Buxbaum et al. Paper suggests 35% of the 3-year life gain in 12 diseases in the US are attributable to new pharmaceuticals. So in the interest of time, I'm just going to take 2 points from my conclusion. The first one, 2 interesting, innovative pieces of work from Che authors, which is what we expect. But my final point is, are we clear where we're going here? And my instinct will be to keep some form of value-based pricing with exceptions for particular challenges, antibiotics and curative therapies. So I'm intrigued by some of Beth's suggested policy outcomes, for example, since keeping the value-based framework, but being much more aggressive about post-patent price reductions in order to get the value. So I'll stop there. Thank you very much.
Thanks very much, Adrian. Can I encourage people who are joining us online to keep posting your questions? We'll deal with those as well as those from the participants here at the end. So I'm going to introduce our second discussant, Keith Derbyshire, who's Honorary Professor at Centre for Health Economics here at University of York. And he's also recently been accepted as a new role as economist member of the Competition Appeals Tribunal. Congratulations for that, Keith. He worked for the NHS for 10 years before being recruited as a government economist into the Department of Health and Social Care in 1992. And he then served under 8 Secretaries of State whilst working at DHSC, and was involved in resource allocation reviews, spending reviews, and the creation, dismantling, and resurrection of the internal market. Impressive. As chief economist and chief analyst at the department, he streamlined the quality assured the production of impact assessments, including getting the department board approval to adopt the 15k cost per quality at the margin when considering the alternative use of funds. And we've heard a fair amount about the 15k today. After leaving the department at the end of 2016, he formed a small analytic consultancy company which has helped over a dozen NHS, care sector and charitable organisations to identify and solve operational problems. Keith, over to you.
Thank you. Very good. Now you've had the professionals and now it's the amateurs' turn. I've got my crib sheet. So first of all, let's see if I can move things on. Okay. So the first thing I'd like to do is to say it's been a long time since I've actually presented to such a high-powered audience of health economists. And I think it will certainly be the last. So the second thing, thank you, Mark and Beth and co-authors, for giving me this opportunity to get back in touch with this very important policy area. And the third thing is the work is important. It's high quality. It's important. It's very timely. And I'll come on to that because there is the renegotiation of the current VPASA scheme. And to me, it's potentially groundbreaking. I've been away from this stuff for 6 months, and the introduction of dynamic efficiency into the consideration of approval, I think, is kind of great. Because there was always at the back of ministers' mind and senior economists at the department, the issue about what would happen if we bore down or bared down too hard on prices. And that was certainly NICE's view at the time. So the voluntary scheme that's currently in place limits the growth in NHS spending on branded medicines. Current spend on NHS medicines, both prescription and hospital drugs, is around 18 billion. And in the last 2 years, it's grown quite rapidly. The net rebate paid by the Association of British Pharmaceutical Industries has grown in the last 2 years quite significantly. So drug spend is important. It's about 13% of NHS revenue departmental expenditure. And also equally important is the pharmaceutical industry in the UK. It's 40 billion pounds of turnover. It spends 5 billion on research and development. It gives a gross value added of 14 billion to the economy and it exports around £23 billion worth of medicines. It's a highly dynamic industry. It's got very high productivity and potential for growth. So it's very timely work that's been done. And the voluntary scheme currently in play is one of a long line of schemes that have all kind of been signed up to by both the industry and government. It's UK-wide since 1957. So what there is in the work presented by Beth, I think, is a series of trade-offs. And obviously, economists can recognise the trade-off when they see one, or in this case, three. I'm not going to read the bullets out. There's the opportunity cost, which we've kind of talked about. There's the impact on what we pay for medicines when they're kind of patent protected, on the future incentives to actually invest and seek out new interventions, new medicines. And this is a dynamic efficiency that we've introduced with this work into the kind of consideration of the results. So the other aspect of it, which I'm not going to talk about today, but has been bothering me quite a bit, is the impact of a UK scheme, not on the global market, because we're a small share of the global market. There will be an impact, but on the location decisions of UK-based drugs companies about what kind of marketplace they want to actually kind of work in and do their clinical trials in. So that's maybe for another day, and maybe when we celebrate the 50th anniversary of CHE, we'll be able to answer that question, which is the one that actually influences most ministers' minds in negotiations about schemes with the industry. So we are now around the negotiating table and positions are being taken. And the positions of the government can be summarised from this press release on the left. This is the left, isn't it? On the left, which was released in spring. So they appear to be very happy with the current arrangement. And the position of the industry from a recent publication by the ABPI is on the right. Now, it goes without saying that the first set of bullets are absolutely correct. And by that, actually, correct myself, I mean the first twin set of bullets. Not all the bullets on the left are correct and all the bullets on the right are incorrect, but the first two bullets in each list can be verified. And I've done that quite simply with routine data. The second two bullets are more questionable, but should be verifiable by actually digging down into what's going on, though I couldn't do it with publicly accessible data. And the third set of bullets is basically the nub of the issue and the one that's addressed in the work that we heard from Beth today and in Adrian's response. So the way that I would present this to ministers would be, first of all, steal Beth's model and put it all on one chart, which is actually the colours have changed in this presentation, and I'm colourblind. I've remembered the colours, so I think the health benefit aspect is in red, and it's the blocked out area where you're in negative territory when the drug is on patent, and you then get the benefit over time when it goes off patent as the price reduces. And that's an important part of the debate, basically, how much the price will reduce. And as we get into more and more expensive, complicated interventions, which might be close to or even above any notional 25 or 30,000 per quality threshold, those benefits won't materialise, even with the most competitive kind of industry in the world. The second chart is about where the money goes in terms of to the manufacturer, but also makes an assumption about the underlying cost with normal profit of production, which I've assumed is £12,500. and we approved this intervention at £25,000 per QALY. So we lose health benefit in the first 10 to 12 years when it's patent protected. We then get health benefits as the price we pay goes down, and the company just then earns a normal profit. What we used to call in the olden days the supernormal profit in those years of patent protection is what should incentivize R&D in particular areas. And a key takeaway message from Beth's presentation and co-authors as well is about how that incentive plays out in terms of prioritizing research into what kind of drugs. And I think that's an important message that the department needs to fix onto. So why would you build such a simple model ready reckoner? Well, basically, it's to answer the questions that ministers would want to know, which is how sensitive the overall results are to changing those parameters. So I've done a fact packet calculation, and this reminds me of the olden days, because I've noticed on the train coming to the workshop that the last row is incorrect. So basically, the first row, this is a very simple example, so I'll quickly run through it. It's 2 people getting half a QALY a year for 50 years, and we've approved it at 25,000. The opportunity cost is 15,000. Patent protection is for 12 years. The price then falls to cost of 12,500. The value of a QALY based on willingness to pay, which is totally unaffordable to the NHS, is 70,000. So that puts both the QALY gain and benefit and the actual price we pay into a cash currency so we can compare the effects. So the baseline is the abnormal profit to the companies to incentivize R&D is 161,000. This is just 2 people, remember. And the net health cost is minus 169,000. So there's no overall welfare gain apart from the incentive to actually invest in new medicines. The bottom row assumes we have a threshold of £17,000, and we're in nirvana because we still get the supernormal profit and we make a huge net health cost. Well, actually, that result's totally wrong. But I noticed it on the train, and the numbers should be the company's share of the profit goes down to 17,000, and the actual health benefit is 60,000. So that gives no incentive for future investment, and we take all the potential health benefit from that particular example. So the others show the sensitivity to, it was mentioned by both Beth and Adrian, have we got an optimum patent protection period? Well, it surprised me by taking it down from 12 years, which is the extreme it could be, to 10 years. You hit the profit, but you also get positive net health benefits just by that 2 years bringing the price down. The other aspect is how quickly we see the price reduction. If it's instantaneous, you obviously get a benefit and it reduces the net health cost. If it takes longer to get the recommendation, you get that result. 6 years is the assumption. And if you actually reduce the price from 25,000 to 20,000, you get that result with the super profit going down and the net health cost approaches balance. So that gives you some idea about the sensitivities of the different parameters. And Beth and Adrian talked about the design of future pricing mechanisms that would hopefully be more sophisticated than a simple rebate scheme. So my final slide, in fact, is the future of a new scheme and what that might look like. And this is lifted from the impact assessment, which accompanied the consultation document, which looks at a new statutory scheme. Now, along with the voluntary scheme, there is a statutory scheme that companies that don't agree to the voluntary scheme actually get put into. So they haven't got an option to kind of go their own way. they have to accept a legal framework which tells them what the rebate will be and all the other parameters as well. And Max is going to be the two fingers, I'm afraid. Yes, so this went out for consultation, and yes, it looks great. So what we're trying to do is encourage companies to put drugs to the market very quickly by exempting the first 3 years from a rebate. We are then going to recalculate the actual level of a rebate based on that award for the early drugs. And we're then, as Beth mentioned, going to target the generic area if there isn't competition. But the level of competition required, it's a very high benchmark. Apparently, if a company supplies anything less than 80% of the total sales, it's a competitive market. It's a very odd definition of competition to me. And my mind boggles at how you can actually have this kind of sophisticated mechanism with a rebate scheme. But that's the current proposal that's gone out to consultation. I just don't see how you can target particular areas of the life cycle and then correct the overall amount to give a fixed cash rebate. Maybe it's possible, but greater minds than me. So I'd like to conclude by just saying the 3 takeaways from my perspective. You cannot simply focus on the opportunity cost of new medicines without recognizing the incentive effect that was on the R&D. Beth and co-authors' work puts this into a sensible framework and begins to make estimates of the innovation elasticity. That innovation elasticity is itself dynamic, and we need to be very careful we don't incentivize the wrong kind of new drugs that are actually too expensive for the NHS. And what I think is missing from the analysis so far is the impact of a particular scheme in a particular country on that country's life sciences industry. So I think that's all I wanted to say.
Thank you very much indeed.
Thank you.